Good afternoon to all the faculties and the delegates present over here. Today I'll be presenting a study on IOP elevation after cataract surgery, a comparative study between the residents and attending surgeons. Cataract surgery is one of the most commonly performed surgical procedures worldwide. Elevated intraocular pressure has been a frequent adverse effect, with incidence being 2.3 to 8.9%. The elevated IOP is most commonly it resolves on its own, but in certain cases it can lead to significant visual loss. This study aims to directly compare the rate of IOP elevation post-operatively day 1 after resident performed surgeries to the surgery performed by attending surgeons, and to examine other variables associated with the development of transient elevation of IOP. A retrospective study on 1,370 eyes was done in a tertiary center. Manual small incision cataract surgery was performed by the resident trainee and the attending surgeon. Preoperatively, perioperatively, and postoperative data were collected. Pre-op data included the patient age, sex, history of diabetes mellitus and other systemic conditions, and IOP using calibrated Goldman applanation tonometer, and perioperative data included any vitreous loss or surgical complications. Postoperative IOP on day 1 was recorded. Any patients who had gone at least one cataract surgery with pre and post-operative data were included in the study, and patients with combined cataract surgery, pediatric cataract cases, traumatic cataract, known glaucoma were excluded from the study. Manual small incision cataract surgery was performed under peribulbar anesthesia. A dispersive viscoelastic agent was used to fill the anterior chamber. In all the uncomplicated cases, after the lens removal, the capsular bag was filled with viscoelastic, and the viscoelastic was removed through coaxial irrigation and aspiration. The result was on post-operative day 1, the incidence of IOP elevation was significantly higher in resident surgeon group as compared to the attending surgeon. Vitreous loss, resident surgeon, pre-existing glaucoma were the significant risk factors. This is the demographic details of the patient. As you can see, the IOP was risen in almost all the cases done by the resident trainee. These are the risk factors for the rise in IOP, which is maximum in vitreous loss, high axial length, and glaucomatous eyes. Transient IOP elevation in the early postoperative has been described after cataract surgery. Postoperative inflammation, release of vasoactive agents, blockage of the trabecular meshwork are one of the reasons for cause rise in IOP. This study concluded that glaucomatous and myopic eyes are one of the significant risk factors for high IOP. Surgical trauma, watertight wound closure, retained lenticular debris, release of the iris pigments, retained viscoelastics. The residents tend to not aggressively wash the viscoelastic material, so they tend to cause a rise in IOP. Prolonged surgery time in the resident trainee cases is also one of the reasons for rise in IOP. Now, the study concludes that the understanding the variables that may be associated with an increased likelihood of an elevated post-op IOP will help in preventing and treating this transient but potentially harmful complication. Thank you.
It was not clear how many did the residents perform and how many did the seniors she had it?
Total cases were 1,370, out of which 1,096 cases were done by the attending surgeons, and 274 cases were done by the resident trainees.
So you compared?
Yes, ma'am. Yes, ma'am. We compared it, but in all the most of the risk factor cases were done by the attending surgeons also only. But still, in all the cases, the IOP was more and significantly more in the cases done by the resident trainees.
Also, you have not mentioned which year residents they were, whether they were second year, whether they third year. So resident trainee, as in the first year, obviously they are the newcomers.
No. Sir, in our institute, like third year trainees does the cataract surgery. Yes, sir.
One thing you said that glaucomatous and myopic, so those were done by the attending surgeon or by the residents?
Ma'am, both, but major cases were done by the attending surgeons.